Hey, I'm Professor Bernardo Cortese. I'm a director of the Interventional Coronary Program at University Hospitals in Cleveland and a professor of medicine at Case Western University. I'm also president of Fondazione RIC and director of DCB Academy. There are many reasons. We can speak about economical reasons, rebranding of companies. The market of the stent is not that rich anymore. But I would love to keep, in a more philosophical way, the real reason why we started dealing with drug-coated balloons since the very beginning. So this is a really true love that started back in 2007 after the first study published by Bruno Scheller for ISR. We started immediately to test these devices for de novo lesions. This is our main setting of interest for DCB. And despite the first study, which was Piccoletto, was a failure, we wanted to invest more our energies and our studies and research programs into this field. And as you said, now everybody is talking about DCB, so everybody is in our segment, in our sector, is jumping, on the DCB arena. There are many CTO guys. A few years ago, if I was trying to ask them, what do you think about DCB? I'm using DCB in CTO. Oh, you're crazy, stent. Now everybody, also in the CTO symposia, everybody is saying, I want to use a DCB because, so everybody is jumping on this for many reasons, but I have to say that we did believe since the very beginning into this technology. There are many technologies, not all of them are the same. There is no class effect, it is quite clear, but I have to say that the several companies did a good job in the last few years in trying to improve the quality of devices. Now we have some devices that are out in the market which work well. Well, for a first user, I would say start from small vessels. Start from a diagonal branch or just a side branch for a bifurcation. That's a good start because you need to get acquainted with this technology within the time. You need to see the follow-up of the patient, either it is angiographic or clinical. ISR is a different animal. We can discuss about ISR if you want. ISR recently had, I would say, well, we wrote that in a couple of editorials, a downgrade in the indication for European guidelines on revascularization, 2024. These guidelines actually, we don't quote this decision to downgrade DCB because in the last 4 years, 6 years actually, between the two guidelines, there were no solid randomized clinical data coming out. There was just one single meta-analysis with a slight increase in the outcome shown by DES as compared to DCB. But the point is that for dealing with ISR, first of all, you have to understand the lesion. That's of key importance. So the first thing that the guidelines should say is that if you have ISR, you have to do intravascular imaging, unless you are really sure of the causes for that. And still, so far you can see outside, because everybody is saying I'm doing intravascular imaging for ISR, but if you see outside, you see that it's the penetration of IVI in ISR is still low, below 50%. So that's the first thing. So you put a stent, you had a failure of a stent, you have to understand why. Because probably you did something wrong or not perfect. Probably, not for sure, but probably. So address that and then you can decide which is the best treatment. Best treatment is not the DCB. I mean, best treatment for ISR, but also for de novo, I would say, is to prepare the lesion correctly. So you understand the lesion, you prepare it correctly. And then in the end, you can decide if to use a DCB or a DES. This is a good question. I thought a lot about this, about which could be the consequences for that, and I cannot anticipate that, but my belief is that there will not be any big change in that, because people are also with our educational activities are understanding how it is important to deal and how it is complex to deal with ISR. ISR is a complex lesion. Also a small ISR, a focal ISR is a complex lesion you have to deal with, okay? So we are understanding that. In the US, DCB came for ISR indication, and they are getting used more and more despite there is so far no reimbursement. There will be one from January next year. So I think that there will be no large impact on the usage of DCB for ISR. Well, there are few areas where I think that DCB should not be deeply investigated. So we use DCB in many cases. In my personal case history, I use it in around 75–80% of the cases, meaning that in some cases, of course, I do blended therapy. Blended therapy is a stent plus DCB, because you always need to use a stent in your cath lab. Not in every case, of course, but in many cases you have to do a blended therapy. So that said, what we need, what is still lacking, is a solid scientific data. But I have to say that there are many trials, many solid trials on the go. We are dealing with Transform 2 with a sirolimus coated balloon versus DES. There is the Solution trial, which is a large trial which finished enrollment. So these two trials will tell us a lot of information about the usage of DCB in a, I would say, real all-comer population, and also with large vessels. But this is something that we cannot avoid, to have solid scientific data. We have the Piccoletto series. We are studying DCB for STEMI, for example. Piccoletto 8 Copernical trial, we are studying DCB for STEMI. So DCB versus DES for STEMI patients. This is another very important area. We know that with STEMI, we never know, we often don't know the exact size of the vessel, also because there is vasoconstriction, there is thrombus. So the potentiality to use a DCB there is important, but we need data. And we are investigating with this type of trials. Bifurcation. We have seen that the more complex bifurcation we deal with, if we put too much metal, the risk of restenosis is there. For example, the left main, we have seen, unfortunately, that so far, if we just take the clinical data, CABG is better than PCI for left main, okay? One of the problems is restenosis. If we are able to tackle this restenosis for complex bifurcation and we treat all of these patients with intravascular imaging, I am sure that we will have good result that will be comparable and maybe on the long term even better than CABG. But all of these interventions should use drug-coated balloons as an adjuvant, in this case for left main, to drug-eluting stent. Why should we use sirolimus? So sirolimus is a very safe drug. It's a more anti-inflammatory drug as compared to paclitaxel. Paclitaxel is more potent in inhibiting intima hyperplasia, also because of a toxic effect on the media. When I say toxic, I'm not saying it's harmful. Well, I use a lot of paclitaxel, okay? But it's an effect that we have seen in several animal data, which is showing how the media is transformed into a fibrin-rich part of the vessel. So this is a matter of fact. So sirolimus is more anti-inflammatory, less potent, and is very effective with stents. So everybody knows that if you put a stent, you don't want to add paclitaxel, because paclitaxel plus metal is associated to an increased risk of aneurysm and restenosis and thrombosis. Sirolimus is working very well with the limus. So that said, we recently presented a Piccoletto 6 data, which wanted to compare directly these two drugs. So what we show, we presented this data at TCT a few weeks ago, what we showed with this study was that paclitaxel still has an advantage in terms of angiographic performance. Late lumen loss can be also negative. In Piccoletto 6, we have a negative late lumen loss. Sirolimus has a good late lumen loss because in this small vessel setting, late lumen loss was 0.1, which is better than any drug-eluting stent. Drug-eluting stent is between 0.12 and 0.20 in a small vessel disease setting in terms of late loss. But the big novelty of Piccoletto 6 is that from the physiological standpoint, having done mu-FR after 6 months, in all of these patients, there is no significant difference. Meaning that physiologically, these two, we use several brands of paclitaxel and sirolimus, they did not show any significant difference from this point of view, which is important because we don't need to have always a negative late lumen loss. We like to see for our eyes a positive remodeling. For a small vessel it's good, but it's not always needed. So what you want to have is to counteract and interrupt any restenosis. That's the most important thing. Another important message that is coming out in the last few years, we have seen with several drug-eluting stents that they are good. But there are two big limitations for drug-eluting stents. One is that on the long term, the events go on. We have several studies with 5 years follow-up or with 10 years follow-up that are showing that every year you still have 2%, 3%, in one study 3.3% of events every year. They never stop. And for events, I'm not talking about all-cause death, but target lesion failure or DOSI. Okay? So with drug-eluting stents, we always have some events. First message. Second message, we have a lot of studies showing that DES are effective and safe, but the problem is that in these studies, they are not used in, for example, a 50, 60, 70 millimeter lesion. There is a registry, a Korean registry, Grand DES registry, which is showing that for longer lesions, the TLF rate is double as compared to DES for shorter lesion. Okay, so these are the two limitations. For that, we wanted to test in a patient-level meta-analysis, which is, the most solid type of meta-analysis, the long-term outcome of DCB as compared to drug-eluting stent. So we collected data from the most important trials on DCB for small vessel disease, because this is the setting where we have randomized clinical data with long-term follow-up so far, and we have shown at 3 years a reduction in MACE with DCB. This is a very important information. We showed that with Picoletto 2, but that was a small study. So it could be also a play of chance that you have lower MACE after 3 years. Now we have 1,500 patients from this patient-level meta-analysis, Andromeda, which are showing that after 3 years there is a significant reduction in MACE. And this is a very important information. It is adding something. We have also to be honest, there are also negative data from DCB. For example, we have the Transform-1 study, which compared the sirolimus coated balloon versus paclitaxel coated balloon, showing that paclitaxel was significantly better, not clinically but angiographically. We have the REC cage-free trial, which was presented recently, which was showing that with DES, simple lesion, large vessels, DES is not going to be occluded. Well, at least with a 2-year follow-up. After 2 years, maybe you still have some events. So there is still work in progress. DCB are working well, but it is not enough. So Andromeda will not change completely the scenario, saying, okay, you have to use for most vessels only DCB. We do that because we know how to deal with the lesions. We know how to prepare the lesions. But so far, we need more data. And hopefully, Transform 2, Solution, and other trials, Picoletto 8, will add more fuel into the segment. As I was mentioning before, there are several important key opinion leaders in the world dealing with randomized data, randomized clinical studies, important registries with drug-coated balloons. Okay, one of these is our foundation, Fondazione RIC, which is based between Milano and Cleveland. Okay, so we are doing research, but what we have understood in the last 5 years, I would say from COVID, is that for DCB you need also a lot of educational activities, because preparing a lesion for a DCB is not the same as preparing a lesion for a drug-eluting stent. It's different. I recently, as I said, joined the US. In the US, one of my colleagues said, in the US, the physicians that are not acquainted with DCB so far, angioplasty is just to put a stent. So just put a stent. So that's different. So with DCB, we have reinvented the art of angioplasty. We have reinvented the art of angioplasty. And I love to say that because I'm really passionate with dealing with complex coronary lesions. One of our studies now is a cardiac, severely calcified lesions, atherectomy plus DCB. We will present this data next year. So all of that to say that we need educational activities. So 3 years ago or something, we created in Milano this DCB Academy. DCB Academy is a fellowship program. So far we have 21 fellows in the globe, which aims to do educational activities on DCB with the proctorships, with symposia during the big meetings. We will organize a symposium at the next CRT. We did one at the PCR previously, and also smaller meetings. We do lessons, and we support all of the scientific productivity of Fondazione RIC. So this is the aim of DCB Academy, and we are really passionate on that. We have incredible physicians that are proposing studies, I would say, almost every week. Almost every week we have a new study to deal with. So that's really a big parameter for me to say that DCB, but I would say interventional cardiology dealing with coronary lesions is well alive.